Hi everyone, Max Simon here from Green Flower, and welcome to another Green Flower live class. If you're new here, the purpose of these classes is to help you learn everything about cannabis from the world's top experts. We'll bring our expert on here in just a sec. He'll give a short presentation all about our topic today, and then we'll move into the other part of the studio for a deep dive Q&A where we can really get into the nitty-gritty around this subject. And today, we're talking about something that is crucially important for tens of millions, potentially even hundreds of millions of people around the world. And that's how to use cannabis to either decrease or quit opioids. Now, if you're unaware, the opioid epidemic right now is creating a painful amount of damage in our world. That can be as simple as the way that opiates really cause the immune system to struggle, to have problems with the liver, to dry out the system and create constipation. There's so many downsides of opiates, and the problem is a lot of times they also don't work very effectively over time. To the extreme cases of people overdosing, dying, or having severe complications. And the truth is, and what you'll discover is that all natural cannabis can be an amazing solution to this crisis that we face in America and around the world. And I am beyond grateful to bring you today somebody who is really leading the cannabis medical revolution forward, and that's Dr. Gregory Smith. Now, Dr. Gregory Smith is the author of a book specifically for training doctors and healthcare practitioners. All right. It's called Medical Cannabis, released just recently, and is a Harvard-trained physician who is also traveling the country and the world in many cases, speaking to healthcare providers about medical cannabis and really how to get their arms around the situation. So please be attentive, take good notes, be respectful, and look forward to a fantastic class. So please welcome Dr. Smith to the stage. Nice to have you here, my friend.
Yeah, nice to meet you.
All right.
Yeah, no, I'm very excited to be here, and this is a topic that means a lot to me. So hopefully my efforts will bear fruit by educating you guys and helping you achieve the goals. So welcome to the class on how to decrease using opioid medications or discontinue them with the help of medical cannabis. In this course, you're going to learn about the devastating opioid epidemic, the challenges of trying to decrease or discontinue opioids, and how to help enlist a medical professional to help you overcome these challenges. You'll set realistic goals and timeframes to decrease or discontinue opioids. And I'll provide you with specific details on what to do day to day to achieve those goals. I'll discuss the side effects that can occur and how to handle them, and what to do if you have a relapse or restart taking your opioids. Also, I'll provide you with several good resources to help you in the community and online. My name is Dr. Gregory Smith. I'm a Harvard-trained physician specializing in preventive medicine. I've been in practice for 30 years. Approximately 15 years ago, I took a course on how to use medical cannabis, and I've been using it as part of my practice since that time. As Max said, I wrote the first textbook on how to, for medical doctors, nurses, and medical students on medical cannabis. So this provides scientific research-founded information for these medical professionals, many of whom have never learned anything about the topic before. I usually like to start patient classes like this with some personal story. However, I think the horrific stories that we hear about daily in the news are enough to understand the huge waste in human life that is occurring from this opioid epidemic. For a significant proportion of people, medical cannabis may be the answer. Let's learn something, shall we? The pain and opioid problem. Over the past decade, there has been an epidemic increase in both pain and opioid use. As it stands, the U.S. has only 5% of the world's population, but uses 80% of the world's opioid medications. There's been a fourfold increase in prescription overdose deaths since 2000. That's 44 deaths a day. Often these deaths are preventable and due to a patient mistakenly taking too much of their prescribed opioids. That's it. To make matters worse, extensive research has not shown long-term use of opioids to be effective for chronic pain. This epidemic is due to marked changes in physician prescribing practices stimulated by pharmaceutical company marketing efforts. Recent research suggests that long-term use of opioids actually increases the patient's perception of pain, leading to higher doses of opioids added to the fact that the patients are regularly being discharged from the doctor's practice because of a positive drug test for illicit substances, usually cannabis. These addicted patients end up seeking street opioids to address their cravings, and they often end up using heroin, the cheapest, easiest way to obtain illicit opioids. Overdoses of heroin contribute an additional 26 deaths a day. Let's talk about opioid tolerance and enhanced pain perception. After injury or surgery, the use of opioids for pain release is very effective. However, with long-term use of opioids, especially more than a month of continuous use, several significant problems can and often do develop. For the most, these chronic pain patients, the original source of the pain has improved or healed. However, after being on opioids for a few months, the patients have developed a physical dependency or an addiction to the opioids. Because the way long-term opioid use changes how we perceive pain, so that even a small amount of residual pain is now being perceived as a lot more pain, which requires, to the patient's mind, more opioids. So the long-term use of opioids actually leads to marked perception of pain being magnified, marked magnification of the perception of pain. Another phenomenon is called tolerance. With higher doses of opioids, the opioid receptors become less and less sensitive. So larger and more frequent doses of opioids are actually necessary to achieve the same level of pain control. With only a few months, a patient can become physically dependent or addicted to the opioids, so that any attempt to abruptly decrease or discontinue the opioids, or even delay taking your next dose of opioids by a few hours, can result in the onset of significant withdrawal symptoms. These symptoms come on quickly. They make the patient feel very sick. They crave any source of opioid, even street drugs. Here's a summary of the early and later symptoms of opioid withdrawal. Get to know them. Anxiety or agitation. Muscle aches diffusely throughout the body. Increased tearing for no reason. Insomnia, a clear runny nose, sweating for unknown reasons, and of course craving opioids. Later on, the withdrawal develops into abdominal pain that is intense, diarrhea, dilated pupils, nausea, and vomiting. These sick patients crave opioids to make the sickness go away. This makes it very challenging for someone to voluntarily withdraw from opioids. If they continue or restart opioids, they often develop further tolerance to the same dose of opioids, so they need even more opioids to get the same effect. If someone is successful in tapering off opioids, then weeks or months later want to take the same dose of opioids that were taken before, this can actually lead to a fatal overdose. During the time that they were entirely off opioids, the tolerance that had developed to opioids has gone away. The opioid receptors have regained their sensitivity. So the dose that they could previously handle may be enough to cause a fatal respiratory depression. Indeed, most of the 44 deaths a day from overdose of prescription opioids are probably due to this unintentional overdose by a regular patient. This problem is well known to the drug companies, and several prescription opioids are not even allowed to be prescribed unless the patient has already developed this tolerance. If the risk of fatal overdose is not enough, long-term use of opioids can cause several severe side effects. The most common side effect is intractable constipation, associated with abdominal bloating, nausea, and colic. Also, decreased testosterone in males and the need to have testosterone replacement is common. Another common side effect is depression, which commonly occurs with long-term use of opioids. These side effects often require the use of other prescription medications that can further complicate the management of chronic pain. What have we learned so far about medical cannabis, chronic pain, and discontinuing opioids? Unfortunately, there is only a small body of good research on the subject of medical cannabis for chronic pain and for opioid withdrawal. However, medical cannabis has been legally available in some states for over 20 years, and there are now over 1.5 million legal medical cannabis patients in the United States. Because of this, there are some good population studies to tell us how effective medical cannabis can be. Also, unlike opioids and benzodiazepines, medical cannabis is very safe, with few and easily avoided side effects and no documented fatal overdoses. Of the 1.5 million legal medical cannabis patients in the United States, 85 to 94% of them are using it for chronic pain. These figures may be biased by the fact that chronic pain is a subjective condition and easier to document than other qualifying medical conditions in states that have medical cannabis laws. Therefore, some people are maybe faking chronic pain just solely to get cannabis for recreational purposes, but that's not why we're here. Let's talk about what the studies do show. 10 to 15% of chronic pain patients were using medical cannabis in combination with other pain medications to reduce the amount of pain medications. An additional remarkable 80% of medical cannabis users report regularly substituting cannabis for their prescribed pain medications. They're doing this without their doctor's advice, and it's working for them. Let's talk about medical cannabis in states with laws versus states that don't have medical cannabis laws. A study from 1999 to 2010 showed a 34% reduction in fatal opioid overdoses in those states that have enacted medical cannabis laws. Another similar study found 28 to 35% reduction in hospital admissions for opioid addiction in those states. A study of Medicare and a separate study of Medicaid prescription use showed a marked reduction in the number of pain and anxiety medications prescribed in those states that had medical cannabis laws. So we know it's working, but we know from an epidemiological standpoint. There's a recent growing body of clinical evidence as well. Some high-quality studies can tell us how effective medical cannabis can be. An analysis of 79 studies found a 30% reduction in pain with the use of cannabis. This is about the same percentage of reduction that we've seen when we use opioids. Another study of pain patients already using opioids showed an additional 33 to 44% decrease in pain levels when cannabis was added. A study in 2016 of chronic pain showed that using medical cannabis resulted in a 64% reduction in the use of opioids, fewer side effects, and remarkably a 45% improvement in the quality of life measures. And finally, a survey of 542 pain patients showed a 39% reduced their opioid dosage and 39% stopped altogether with the addition of cannabis. So the goal of this class is to help you, with the help of your medical provider, get your dose of opioids significantly reduced and possibly stop using opioids. The problem is the doctor's resistance to cannabis. The biggest obstacle to getting help using medical cannabis to decrease or discontinue opioids is resistance from the medical community. This is not something you want to do without advice, support, and monitoring by a medical provider. Unfortunately, over 95% of doctors to this day have never taken a class or had real-life experience recommending medical cannabis to a patient. They have never learned about THC, CBD, dosing cannabis, or the endocannabinoid system in the body. You're about to learn. They're also concerned about the stigma of recommending a recreational drug. So in my experience, most physicians that are prescribing the opioids and benzodiazepines will not be willing to help their patients use medical cannabis. If you ask your medical provider for this help and they won't provide it, there are 2 good websites available that will help you find a licensed, trained, and experienced, compassionate medical provider in your area. That medical provider can work with your regular doctor to help you add medical cannabis to your chronic pain treatment. If you get a separate doctor for medical cannabis, it is very important that your regular doctor know what you're doing and agrees to work with you and the other doctor. If your medical provider is at all willing to think about the possibility of using medical cannabis, you can refer them to my report, Using Medical Cannabis for Opiate Sparing and Opioid Tapering in Chronic Pain. This is currently available at cannabis-md.com, but will also be published in several other magazines and journals. This report provides a clear, concise, and well-referenced discussion on the subject of how to use medical cannabis to help patients on long-term opioids and benzodiazepines. The following are the recommended sites to find a compassionate medical provider, dispensaries in your area, and to learn for yourself how cannabis works with several conditions, not just opioids. This is very important. After starting cannabis, your urine drug test will become positive for THC. And the doctor providing you with opioid medications needs to understand and agree with this. You and your opioid prescribing doctor will usually need to sign a new opioid medication contract. The doctor recommending the medical cannabis may also have a similar contract to sign for the cannabis. So let's talk about medical cannabis as an adjunct, a separate additional medication. Several medications are already available to use or minimize the dose of opioids, and these are called opioid-sparing medications. They spare the amount of opioids necessary for the same amount of pain relief. Opioid-sparing medications include NSAIDs such as Aleve, ibuprofen, Tylenol, antidepressants, and anticonvulsant medications. Cannabis is also an excellent opioid-sparing medication. In my opinion, better than those I just mentioned, for a variety of reasons. Cannabis, in addition to being opioid-sparing, reduces the amount of symptoms that go along with chronic pain and opioid use, such as joint inflammation, muscle spasm, anxiety, depression, nausea, constipation, and poor appetite. So the goal of adding any opioid-sparing medication is to reduce the level of pain, reduce the side effects associated with opioids, decrease the development of opioid tolerance with the constant need to increase the doses of opioids. However, the most important goal is to decrease the number of accidental overdoses resulting in hospitalization or death. So if opioid sparing is successful, then after discussion with your medical provider, it may be used to completely withdraw from all opioids. So initially we spare the opioids and then we withdraw entirely. It is important to understand how the endocannabinoid system is involved with pain. This class is not meant to teach the intricate workings of the endocannabinoid system, which is abbreviated ECS. For the more detailed discussion of the ECS, how it works, I recommend that you read Cannabis 101 at www.cannabis-md.com. The ECS is a huge and vitally important system in the body. It was only discovered in the 1990s. Most doctors have never heard of it or had a class about it, how it works. It has receptors in the brain, more receptors than any other neurotransmitter system, such as ones you may have heard of: dopamine, serotonin, histamine, acetylcholine. It has more than any of those. It has the second highest numbers of receptors in the body and predominantly works in the immune system cells, the liver, the spleen, and the GI tract. It has to do with maintaining homeostasis or balance of many other systems in the body and brain. It is like the braking system for a wide variety of other systems. So there are at least two naturally produced chemicals in our brain and body that attach to these receptors. They are called endocannabinoids. And as far as this class is concerned, the ECS puts the brakes on how much pain we perceive in our brain and how much inflammation, swelling, and muscle spasm we generate in response to injury or illness. So cannabis works on pain and helps spare opioids via several mechanisms, not just the ECS. There are hundreds of ingredients in cannabis. However, for this class, it is important only to think of the two most medically active ingredients: cannabidiol, CBD, and tetrahydrocannabinol, THC. CBD and THC present in cannabis mimic the natural endocannabinoid chemicals. They cause the same effects on the ECS as these natural endocannabinoids. THC causes euphoria, getting high. People who become dependent get addicted to the THC. THC is associated with all of the side effects from medical cannabis. Because of issues associated with THC, we try to keep any one dose to no more than 10 milligrams of THC per dose. CBD, on the other hand, does not cause euphoria, does not create dependency, is very safe with minimal risk at even hundreds of milligrams several times a day. So CBD, when taken in balanced doses with THC, blocks most of the side effects and euphoria caused by the THC. For these reasons, medical cannabis for pain management purposes is a balanced combination of THC and CBD. The most common combination or ratio is 1:1, CBD of THC. For example, 5 milligrams of CBD and 5 milligrams of THC per dose. Some strains of cannabis have lots of CBD and very little THC, such as Charlotte's Web, which is used to treat intractable seizures. Other strains have lots of THC and very little CBD, such as almost all recreational strains of cannabis. So in order to have a combination of equal parts CBD to THC, we often need to combine strains or have extracts. So medical cannabis reduces pain using the ECS. It works in the centers of the brain and the nervous system that recognize and magnify pain perception. The THC attaches to the cannabinoid receptors and decreases the amount of pain that we perceive. This decreases the amount of opioid necessary to block the pain. There's also some evidence that THC helps reduce muscle spasm that can contribute to the sensation of pain. CBD, however, works in the body at the site of the injury where the disease is active. CBD attaches to a different set of cannabinoid receptors at the site of the injury to turn down the inflammatory response. This decreases the amount of painful swelling and inflammation at the site of the injury or the condition. After cannabis is inhaled, ingested, or absorbed through the skin, the THC and CBD eventually make it into the bloodstream. And once in the bloodstream, they are rapidly absorbed and transported around the body and across the blood-brain barrier into the brain, where they mimic the effects of our natural endocannabinoids. Another separate way cannabis reduces pain and the need for opioids is by improving how opioids work in the brain. So just as we have natural endocannabinoids in our body that attach to the cannabinoid receptors, there are natural chemicals in the body that are designed to reduce pain by attaching to opioid receptors in the brain. These natural chemicals are called endorphins. So opioid medications mimic endorphins. Opioid medications attach to these opioid receptors, and this results in reduced perceived pain in the brain. Both THC and CBD work by helping magnify the effects of opioids. So the person gets decreased pain perception with the same amount of opioid. So what about opioid receptors? Opioid receptors are present in large amounts on the brainstem, in addition to many other areas of the brain. But because they're on the brainstem, opioid medication can cause life-threatening respiratory depression. By attaching to these receptors in the brainstem, it makes the brain stop sending messages to breathe, and we stop breathing. Cannabis does not attach to these brainstem receptors, so cannabis can be used without life-threatening issues of respiratory depression. And this is what most people die from, is respiratory depression. Let's talk about acetaminophen or Tylenol. It is also an opioid-sparing medication. It's again commonly known as Tylenol, which I'll use for the rest of this talk. It is the most commonly used OTC pain medication. In fact, many opioid medications are a combination of opioid and acetaminophen, almost all the ones that you've heard of. Lortab, Vicodin, oxycodone, Percocet, and Norco. They all have acetamin added to the opioid because acetaminophen magnifies the pain-relieving effects of the opioid. Again, this is what we call opioid sparing. Tylenol has been used for over 100 years, but it was not until very recently that we knew how it worked in the body. Again, only a few years ago it was discovered that when we take Tylenol, it is metabolized in the liver and turned into another chemical. It is this chemical that blocks pain by attaching to cannabinoid receptors in the brain. It also blocks an enzyme resulting in increased amounts of natural endocannabinoid activity in the brain. So Tylenol works the same way that THC works, by attaching to the ECS receptors in the brain that decrease the perception to pain. Unlike NSAIDs and Advil and Aleve and aspirin, Tylenol has no GI, cardiac, or renal side effects. However, high doses, especially when taken with alcohol, can cause severe liver damage. Because many patients using opioids often take many opioid pills a day that also contain Tylenol, the amount of Tylenol in each tablet was reduced a couple years ago by the federal government from 500 milligrams to 325 milligrams. However, many chronic pain patients take up to 8 combination tablets a day. That's very typical. That's 2,600 milligrams of Tylenol. So something to be concerned about with your liver. We'll talk about beta-caryophyllene here. Beta-caryophyllene is a terpene, a chemical found in large quantities in some strains of cannabis. It can be considered for opioid sparing as well. It attaches to the endocannabinoid receptors in the immune system, resulting in decreased inflammatory pain and swelling at the site of injury or disease. So let's determine if medical cannabis for chronic pain and opioid sparing is a good idea for you. I can't understate too much how important it is to work with a trained and experienced physician to determine if you should attempt to decrease or discontinue opioids by using cannabis. The side effects of opioid withdrawal can get severe, requiring hospitalization or sometimes fatal cardiac arrhythmias. The physician may need to prescribe certain potent medications for a short period of time during the initial phase of tapering. Also, some persons should not use cannabis because of the increased risk of psychosis or developing a dependency on cannabis. In reality, though, the plan that I described below is generally very safe, not associated with any of the things I just described, with minimal risks of psychosis, euphoria, or dependency. And if successful, the long-term benefits of substituting cannabis for opioids for pain control far exceed the theoretical risks that I just mentioned. This program uses a gradual, safe tapering off of the opioids while systematically substituting doses of THC and CBD. The rate of opioid tapering is slow, minimizing the chance of withdrawal. Also, the concomitant use of cannabinoids helps reduce the risk of tolerance and reduce the dose of opioids if they are abruptly restarted. Let's talk about preventing opioid dependency in the first place. An ounce of prevention is worth a pound of cure. Never has this statement been more true than for the long-term use of opioids. Short-term use of opioids for acute pain, such as after surgery or injury, is very effective and generally safe with minimal issues of tolerance, overdose, or addiction. However, the longer the short-term use of opioids continues, the risk quickly grows. A recent study showed that half of patients continued on opioids for more than a month will still be taking opioids 3 years later. Since most pain from surgery or injury requires opioids for only a couple weeks, ongoing use of opioids for longer than 2 weeks needs to be questioned. There are plenty of non-opioid pain medications that can control the level of pain after the initial 2 weeks. Unfortunately, opioid medications cause a pleasant euphoria. I don't know if that's unfortunately, but they do, making their ongoing use very pleasurable for the patient. If the medical provider is not keeping a close eye on the indications for opioids, he may continue prescribing the opioids long after they are really necessary for medical purposes. Benzodiazepines, which are often prescribed at the same time as opioids, are also associated with a pleasant euphoria and habit forming. And this further compounds the risk of life-threatening consequences from the use of opioids. If you're started on an opioid for an acute injury or surgery, you should advise your doctor that you want to stop opioids and want to use non-opioid pain medications as soon as possible. Let's talk about the usual approach to decreasing or withdrawing from opioids. This is if without cannabis. I want to briefly mention the usual medical approach. And what this entails is the quick method, which is detoxification, requires close medical supervision and nursing supervision, is only available in a hospital setting and lasts several days in the hospital. The doctor will use several potent medications to counteract the sometimes severe withdrawal that occurs. And this detoxing off opioid medications is not used very often, is more for heroin addicts. A more reasonable approach is to gradually decrease the dose of prescribed opioids by 20 to 30% each month, until the patient can either can't tolerate the pain without opioids, or the patient stops opioids altogether and uses non-opioid pain medications. This approach usually takes 3 to 6 months and can be very effective. We're going to talk about types of medical cannabis at this point. If you want to learn more details about types of medical cannabis and the method of taking medical cannabis, I recommend again, the article Cannabis 101, which mentions at the website, cannabismd.com. For simplicity, I will only discuss cannabis that is quick relief and cannabis for long relief. So cannabis for quick relief and cannabis for long relief. Just as there are opioid medications that are released slowly, and then another type of tablet that is released quickly, we have different methods of taking cannabis. And this depends on how the cannabis is absorbed. And you will learn about that at Cannabis 101, how to get different absorption. Okay, let's talk about taking the first step. You have a medical provider that's helped you obtain medical cannabis. Also, the doctor prescribing your opioids is in agreement with the plan to taper opioids and using medical cannabis. And now you're ready to start. In general, the best form of cannabis to start with is in a ratio of CBD to THC of 1:1. It is best to have at least 2 forms of medical cannabis. One that is slow release, such as extracts, edibles, or tinctures put into teas. These are for use throughout the day and night and last up to 6 hours per dose. The other form is a fast-release form, such as a vaporizer, a tincture held under the tongue, oral mucosal spray, or smoked bud. These are for breakthrough pain. They work quickly, within 20 minutes, and only last for a little longer than an hour. If it is possible, get a cannabis medication that is high in beta-caryophyllene. The staff at your dispensary should be able to provide you with cannabis medication that is high in beta-caryophyllene. Remember, this works in the ECS to decrease inflammation and pain. If you've already been using recreational cannabis, it is advised that you stop cannabis for 6 days to clear your cannabinoid receptors off and let them regulate to a healthy level before starting this program. That's important. It's a 6-day cleansing for your opioid receptors. Let's talk about getting adequate pain relief. The initial goal of adding medical cannabis is to determine how much of a dose of THC and CBD are necessary to get adequate pain relief. If you're able to get good pain relief without taking your next dose of opioid, then this is a very good indicator. However, you do not want to entirely stop taking opioids if you have been taking frequent doses for a long period of time, as you may have withdrawal symptoms and crave opioids. The plan is to gradually withdraw from the opioids over weeks to sometimes months, using 3 daily doses of slow-release cannabis. If the slow-release cannabis does not control the pain after 90 minutes, then take half your usual dose of opioid medication. The combination of cannabis with half your usual dose of opioid usually gives you the same amount of relief as taking the full dose of opioid alone. A good starting dose is 2.5 milligrams each of CBD and THC in a slow-release formulation 3 times a day. This is a low dose. It would be unusual to have any side effects from cannabis from this kind of dose. After 2 to 3 days at this dose, if you're not getting much pain control, increase to 5 milligrams of CBD and THC 3 times a day. Do your best to keep taking doses at the same time each day to establish a rhythm in your body. This dose can be gradually increased every 2 to 3 days. Next dose, 7.5 milligrams, and then finally 10 milligrams of each per dose. After reaching the 10 milligram dose of CBD and THC, the goal is not to increase the amount of THC any further. The next step is to add more CBD. So you'll need to obtain CBD to THC in a ratio of 2 to 1, 3 to 1, 5 to 1 from your dispensary. With these higher ratios of CBD to THC, you can keep increasing the amount of CBD, still keeping your THC dose to 10 milligrams per dose. The goal at this point is to achieve enough pain relief with your cannabis so that you can consistently take half the dose. After several days of taking consistent pain control, you can cut that opioid dose in half again, gradually tapering off the frequency and the dosage of your opioid pills. This will result in a natural withdrawal from opioids and is very unlikely to result in any opioid cravings or withdrawal side effects. Your physician can help you by providing you with lower dose opioid tablets, 5 milligrams and 10 milligrams instead of 20 or 30. This will make it easier for you to gradually taper down the number of milligrams of opioids that you're taking each time. If there is not enough pain control with the cannabis alone, instead of taking your opioid pills, take 1 500 milligram Tylenol. That Tylenol works by getting converted to a chemical that attaches to the same cannabinoid receptors as THC. So this is a nice way to increase the THC effect without taking higher doses of THC. Warning, do not take Tylenol tablets if you're also taking opioid pills, as they also have Tylenol in them, and also don't drink alcohol when taking Tylenol because of the possibility of liver damage. Let's talk about breakthrough pain. Some chronic pain patients will get breakthrough pain as their opioid medications wear off. Because cannabis lasts longer in the body than opioid medications, breakthrough pain may not happen. However, if you have intolerable breakthrough pain between doses of your long-acting cannabis, take a small dose of fast-acting cannabis, such as 1 or 2 hits of a vaporizer, a joint, or 2.5 milligrams of tincture under your tongue. Give this 20 minutes to work before consider taking a fast-acting opioid pill to deal with your pain. However, after 20 minutes, you still need to take a fast-acting opioid pill. Try breaking that in half to help, again, tapering off the opioid doses. Remember, the higher the dose of opioid medications, the more frequent you're dosing, the longer this process will take. Be patient. Don't rush. It took a long time to get this level It took a long time to get to this level of opioid medication. It's going to take a while to gradually discontinue them. Now I want to mention the problems and pitfalls. Some pain conditions never respond to cannabis and non-opioid medications. It's just a fact. It has to be accepted. Our initial goal is decreasing the amount of opioids being taken, and that may be all you're going to achieve. However, using cannabis and reduced doses of opioids should greatly reduce your chance of unintentional overdoses and significantly improve your mood and decrease opioid-associated constipation and other side effects. I need to warn you here. If you attempt to take the high-dose pills that you used to take long after you've quit taking them, you could have a fatal unintentional overdose. If you have a craving or want to try an opioid or benzodiazepine after you have been off of them, contact your doctor before taking any medication. Finally, before I go into the summary, I want to say that you can go to Google Play or to iTunes and find several apps. I can't mention the ones that are currently in favor at the moment because they keep changing. But what you're looking for is an app that will help you track your pain level, track your cannabis medication use, your opioid medication use, and your side effects. And again, there are several out there, and they're usually cheap in the $1 to $3 range. With these apps, you can make a printout and bring it into your doctor to help him with your decisions on changing your medications. In this slide are some local support groups where you can interact with people going through the same process you're going through. Finally, let's get to a quick summary and then maybe a question and answer session afterwards with Max. The initial goal is to decrease the dosage and frequency of opioid pills. If successful, consider quitting opioids altogether. Work very closely with your doctor prescribing the opioids, and you may need a separate doctor for the cannabis. You want to prevent opioid withdrawal symptoms or craving for opioids while tapering off of them. And very importantly, you want to prevent unintentional overdoses of opioids by restarting opioids after they've already been stopped. Thank you. I hope you enjoyed the class. And here,
All right. Wonderful. Thank you so much, man. So I have a bunch of questions for you. We're going to go ahead and set up in the other part of the studio and get into our Q&A. Sound
great.
good?
Look forward to it.
All right. Come on.
Welcome to Green Flower Insider, an exclusive online membership that gives you unlimited access to an ever-growing library of credible cannabis classes from the world's top experts anytime you want. No matter where you are in the world, you can learn how to use cannabis as medicine, find the perfect cannabis dose, start your own cannabis business, make your own cannabis-infused edibles, oils, and tinctures, and so much more. Plus, you'll become an exclusive member of our Insider community, where you can talk about everything cannabis with people you trust and respect. Ask your questions and get trustworthy answers. Exchange ideas on important cannabis topics like changing the laws or getting safe access. Discover resources to help you grow better cannabis. Or start your own cannabis business. And connect with other like-minded cannabis enthusiasts who transcend the outdated stigma. Yes, this is the cannabis community you've been looking for. So sign up now and become a Green Flower Insider today. A world of credible cannabis education is right at your fingertips. Visit learngreenflower.com.
Hi everyone, welcome back. I'm here with Dr. Greg Smith and we're talking about cannabis and opioids and more importantly how to transition away from them. And what I was left with when I was watching that is this feeling of how difficult it must be to be in this opioid kind of loop, if you will. And so from your experience in helping people transition, what's the most difficult part from, using cannabis to move away?
And the opioid loop, that's a nice way, spiral. So the most difficult is taking that first step, and I hope the class gave you all of the equipment and tools to take that first step. As you may remember, the first step involves your opioid prescribing doctor and a new doctor that's going to be prescribing or recommending cannabis. and working as a team, the three of you working as a team. And that's often hard to do, to get docs to work like this, especially with cannabis. There's still that whole stigma among most doctors. So that's the hardest step, is to get all the team together.
When somebody's just starting this process, how much cannabis or cannabinoids do you suggest they begin with?
Good question, because that may not have come across as nice as I would like it. So I'm going to answer it and then add up one little other point. So 2.5 milligrams each in a 1-to-1 ratio in a long-term cannabis. Just so we understand long-term, it's anything that goes into your stomach and then it will go through your liver. And so that is an edible, that's an extract, that's a tincture that's been put in tea, for example. If you put the tincture under your tongue, it's now a quick, rapid acting cannabis. If you put it in tea and drink it, so it goes in your stomach, it's now a slow release. So slow release, 2.5 milligrams each of CBD and THC. The additional comment I didn't get across is the 10 milligrams of THC per dose. That is what we'd like to keep you and not exceed that. Yeah, I have to admit there are going to be some patients out there that will go up as high as 15 milligrams of THC per dose. So as long as you aren't getting high, that's okay. And I tell my patients, if you're getting high, you're having too much THC. And this is an important concept. I'm sorry for extrapolating here, but if you're getting high, you're flooding your you're flooding your cannabinoid receptors. And that doesn't happen in nature. In nature, this cannabinoid is made, it's instantly dissolved in a fraction of a second. We make a little bit of our endocannabinoid, it lands in a receptor, and it's all gone in a fraction of a second. But if you're getting high, then those receptors are just filled with cannabinoids for minutes to hours, and that doesn't happen in nature. And so you don't want to do that, because that's going to start creating some tolerance to the medicine. So we'll start needing more and more medicine if you get high when you're taking your medicine. So long answer, sorry.
No, it's great. So you're suggesting that you can take cannabis for pain, even if it's THC, but avoid the psychoactivity.
You need to. If you're getting psychoactivity, euphoria, getting high, they're all the same thing, then you have too much. Okay, so this is not pain relief by intoxication. I'm quoting someone, I think it's Ethan Russo, but this is not pain relief by intoxication. This is pain relief because we're turning down the volume on how we perceive pain. And so it is not required that you don't want to get high, because you flooded your receptors.
I think that's a really unique distinction that you don't see talked about very often in the cannabis space. I think that there's a perception that you're taking cannabis and you're kind of getting that euphoric feeling, and that's what's causing the pain to go away. But really what you're saying very clearly is that when you're taking cannabis specifically to mitigate pain, that there's actually a decrease in the pain signaling. And if you take too much, that you're almost overriding that effect with just the euphoria.
You're right. So I think that people have emotional pain, emotional issues, and they get euphoric with alcohol, cannabis, or other substances to deal with that emotional pain. But this is physical pain from a physical injury, a fracture, a surgery, an accident. And if we're just dealing with physical pain, not emotional pain, then yes.
So how important is it that CBD is present with the THC regimens for pain?
Very important for two reasons. One, the entourage effect of the CBD. Remember, CBD, really most of the effect of CBD is to enhance our natural endocannabinoids. Okay, it blocks the enzyme, so we have more of our natural endocannabinoids. So that's its main effect. It's a mild CB2 receptor agonist, so it mildly has some effects from doing that. But when we're up there in the brain and we're dealing with pain in this class, we need to think of it as just increasing the amount of our natural endocannabinoid tone in the brain. So it's needed there, and it's also needed to counteract the side effects of THC. Remember, all of the side effects, all the major side effects, as well as dependency and the possibility of uncovering psychosis, are all due to THC. CBD dramatically reduces that. And I'll give you some great examples that are only relatively recent. There are thousands of patients were studied by GW Pharma in several studies around the world with over 1 year use of their product. Their product, Sativex, is 1-to-1 THC to CBD. It's exactly what I'm recommending here. So unlike most conditions, I can tell you there is thousands of people that we've had randomized clinical trials, which is great. And no one got dependent, no uncovering of psychosis. So all the things you hear about that maybe some politicians want you to think can happen with medical cannabis didn't happen with GW Pharma's research. And that's the CBD is blocking those adverse effects.
And so how important is THC in this process?
Huge. So THC is the main, so it's a CB1 receptor and the THC in the brain that is turning down our perception of pain at the neuron level. So the neurons, the pain message comes up, there's the pain message, I hurt my ankle, it's coming up my spinal cord, it's going to my brain, and then I have THC telling the neuron to not send as much signaling about how much pain is being perceived.
I found that to be one of the most interesting things that you said in the class, where prolonged opioid uses enhance the pain signaling that's happening in the brain. And I just found that so interesting as a thought process for us to consider why cannabis could be a better approach for pain.
So just so we understand that, yes. So there's two things. One, the longer you take high-dose opioids, the more tolerant you get, the more opioids you need for the same amount of pain relief. So you keep escalating your opioid dose. Separate is what you just mentioned, is all the studies of opioids are in short-term use. So until only about a decade ago, no doctors would think of using opioids for these conditions. It was for people dying of cancer, palliative care in their last few months of life from severe cancer, or short-term use right after surgery or a fracture. That's all opioids were for. And there's no studies to show that it's good after a few months for pain relief. Well, it's only been in the last couple of years that studies have been done where they were trying to show that these medicines were good for long-term use, that they found out it actually changes the way the opioid receptor responds and increases the signaling. So long-term opioids are causing increased signaling of pain.
And you know, I mean, maybe this is because I'm not super well educated in pain management, but I found it interesting to think of the fact that it's not necessarily that pain is happening tremendously in the body as much as it's the signaling that's giving us the sensation that we're having pain, and that if we just settle down that signaling, then we experience less pain.
True. So you injure yourself or you have surgery. Within a few weeks, the swelling and inflammation is calming down, the tissues are quieting down, and so the origin of pain is getting less. However, the other manifestations of the pain start becoming more and more important, and if you've been on opioids, those start getting magnified. So yeah, it's healing. The tissues are healing after a few weeks, and so the pain is not so sharp and knife-like. It's more dull and achy.
So let's pretend somebody is going to start soothing their opioid routine by supplementing with cannabis. What typically goes wrong in that process? Meaning, what are things that people need to learn to avoid?
Okay, I think the biggest thing that goes wrong is I recommend the long-term cannabis, the slow release, 3 times a day. And that comes in various formats, but in general, it's going to be about 90 minutes from when you take that edible or took the extract until it starts having an impact. So that's a long time when you're in pain. And so you're going to think, oh, it's not working, and then you're going to take your opioid. So that's a big problem. So it's very important. You're already on your opioids. You know that you take your opioids in morning, lunch, and dinner time, for example. Well, therefore, you should try your cannabis dose 90 minutes before you've already been taking these opioids for years. You know when you take them.
The timing thing.
The timing. So 90 minutes before. And 90 minutes is 90 minutes. And it's a long time. But you weren't going to take your opioid until like 9 a.m. after breakfast, for example. Then you take your cannabis dose at 7:30. And so then by 9 o'clock after your breakfast, if you don't have enough pain relief, take half the amount of opioid because the cannabis is going to have about 30% decrease in pain. So take half your amount of opioid. But that's the biggest problem, that 90 minutes.
I think that's a really valid piece of education to make sure people understand the timing of it. I had such a good question and it just flew out of my head. Hold on, give me a sec, it'll come back. Opioid, cannabis. Oh, so you talk about the slow release strategy as the predominant one. And I'm not exactly remembering how much you addressed this in your talk, but is there a downside to doing instant kind of methods like vaporizing or vape pens or those kind of things if people are in pain?
No, but so most, just so you understand, you may not understand, with most people that are on chronic opioids have two types of pills from their doctor. They have a slow release pill, and then they have one for breakthrough pain, which is fast release. So what I've done is paralleled that with cannabis. So I have the slow release cannabis, the substitute for the slow release opioid, and then you have the fast release cannabis. As the medicine's wearing off, you start to get some severe pain, or if you tweak your back or your whatever knee, it tweaks, it hurts a lot more than it was hurting. You can take 2 hits off a vape, 2 hits off a joint, or 2.5 milligrams of tincture under your tongue. That's when it's fast. And that's your fast release, and it works within 9 to 23 minutes. So I average it out at 20 minutes.
I guess it's, I think they say it's 1 to 2 milligrams per puff, right? Isn't that somewhere? So,
correct.
1 to 2 puffs would probably
1 to 2
be
puffs,
fine.
yeah.
And so one of the issues that a lot of people face when they're trying to use cannabis as medicine is maybe they have access to a 1-to-1 product, a THC to CBD product, or maybe they have access to just a THC product and then they have to order some kind of CBD product from someplace else. Do you have any objections to people doing that for pain if that's the only way that they can get both compounds?
No, not at all. You often have to do that. And actually, for the vaporizer, I recommend a CBD-only vaporizer. Get your 30 milligrams of THC, 10, 10, 10. And then when you have breakthrough pain, do your CBD. So you're increasing your CBD while you're getting plenty of your THC. And don't forget that Tylenol tablet. That little 500 milligrams of Tylenol, it goes and stimulates your CB1 receptors just like a THC does. And that's that one little tablet. 3 of those a day is only 1,500 milligrams. It's not very much in the body. Again, don't drink alcohol with it, but not very much. And it's adding to the 30 milligrams of THC you're already getting.
And so I heard you very clearly say to do your best to not go above 30 milligrams of THC per day. But did I hear you correct that sometimes if the pain is still lingering, the going higher CBD makes more sense?
Yes. So you state your 10, and the pain's, you're not getting enough pain control, and people will know what pain control because it's function. Can I get up and go to work? Can I go get the kids? Can I do the grocery shopping? And if the pain's limiting you from that, then you're not getting enough pain control. Mm-hmm. So then you want to go to a 2-to-1, 3-to-1, 5-to-1 CBD to THC. You stick with your 10 milligrams of THC, but you could have 50 milligrams of CBD in the same dose.
And this might sound like an obvious question, but it's useful to ask, which is if you're practicing this regimen the way you are, it shouldn't be incapacitating you during the day, right?
What? The dose?
Well, yeah, taking THC and CBD, I mean, you should remain functional throughout the day if you're doing this correctly, right?
Oh, yes. As I tell my patients, if you're getting high, you're taking too much medicine. So our goal is not to get to 10 milligrams of THC. Our goal is not to go above 10 milligrams of THC. And I'm going to say the vast majority of my patients, just so you understand, are on 5 milligrams 3 times a day. Vast majority. But 10 milligrams is that point that you can start getting high. Mm-hmm. And then, that's function. You can't go pick up the kids from school.
Yeah. Does cannabis help with the symptoms of withdrawal from opioids at all?
Oh yes, it does. It does a couple things. The worst symptom of opioid withdrawal is opioid craving. And I don't know if you've been around it, but you can imagine it's craving. That is the word. And these people will do anything to get that dose. And and some terrible, terrible stories, especially when we talk about getting street opioids and things like that. So they will do anything for that craving. So cannabis actually blocks our reward centers, and so we don't feel those rewards. So there's a reward setting. It works with cocaine and opioids, and even gambling. It's all the same reward center. So it works on that reward center. So the craving, which is the most intense symptom, is affected, and then of course nausea, vomiting, anxiety, agitation. When it's the right dose, the 1-to-1 cannabis, it works nicely on that and decreasing those symptoms.
What would you say to doctors, lawmakers, policymakers that would say to you, using cannabis as a substitute for opioids is just substituting one addiction for the other?
Well, they're wrong. So I would tell them to go, I mean, if they want science, because we all like science and studies, so the nice thing about the GW Pharma studies, which were, this is 1-to-1 cannabis, over a year, several thousand patients on this stuff for over a year. No dependency, no uncovering of psychosis. And there was some mild euphoria. So, you know, and we want mood elevation, we don't want euphoria, but you know, what is mild euphoria? I think mood elevation is what mild euphoria is. So all of these things are good. So there's no addiction with this kind of cannabis, at these levels, there is no addiction. All the studies about addiction were done with recreational cannabis, which is 15% THC, less than 1% CBD, typically 20 or 30 milligrams per dose, several times a day. This has nothing to do with what we're doing here.
I really appreciate you coming at this just 100% from the medical side, because I think it takes these kinds of conversations for people to really understand, while the recreational thing exists, and that's fine that it exists, this is something so different.
Yes. Just, you know, there's opioids for pain control, and then there's abusing opioids with heroin, and they're both opioids, but you know, one's entirely different than the other. The problem with this group of patients, why I really particularly am compassionate and fervent in my feelings, is these are just regular people that had surgery, they fractured their arm, and got addicted to opioids by their doctor. And they're not on purpose, the doctor's intentions were good. The opiates are pleasurable. The patients are going to keep asking every month when they come back, oh yeah, it still hurts. I'm not ready for just ibuprofen. I still just need one more month of opioids. And the doctors have been giving them to them. So we did this ourselves as a community, the medical community, and this is part of fixing it.
Yeah. All right, I'll take some questions from the audience. I've got one more to ask you, which is, there certainly is, here, I'll take these, thank you. I think there's certainly some concerns about the amount of Tylenols and ibuprofens that people are taking every day. Do you think cannabis could be a substitute to reduce the amount of those kinds of over-the-counter medications that people are taking as well?
Oh, yes, yeah. In fact, you probably have courses on arthritis. The most common reason why people are using ibuprofen, Aleve, Advil are just degenerative arthritis. Just old age arthritis, creaks and stiffness of the bones and achiness. And you know, migraine headaches are probably another good reason to take those over-the-counter products. But yeah, you can use these kind of doses, this kind of medicine. You're not getting euphoria, and it is helping with the pain.
Yeah. We get this question pretty much in every class, and it's always because it's related to whatever the topic is.
It's the same person every time.
Right. Is there a strain that I should look for if I'm trying to wane off of opiates?
Yeah, I'm not a strain person, and the doctors I educate, we keep away from the strain issue. I think we could go on and on why that is, but certainly in the last decade, a strain is not a strain is not a strain, and you don't know what's in there. So we deal with milligrams of THC and CBD. All the dispensaries I know of will have next to the flower that you're going to buy what percent of THC and CBD. It'll often have the most common terpenes percentage in there, and the terpene that we like with pain is beta-caryophyllene. Because that's a CB2 stimulator, inflammation and swelling out in your body. So we like beta-caryophyllene, so we like something with a high dose of beta-caryophyllene. We don't like myrcene. Myrcene, it used to be they said that indica was indica-couch, and that's been disproven. So indica-couch is from myrcene, and so we don't want a lot of being like lazy and overly relaxed when you're trying to be functional. So low myrcene, high beta-caryophyllene, and 1-to-1. Whatever that name is.
Yeah, whatever that strain is, right? So this person is basically asking, if I was to read into this question, it's how do I talk to my doctor? Because I think this is, already a touchy subject when we're talking about opioid addiction or opioid dependence. How do you, as a doctor, suggest that people approach this conversation?
Interesting that's a question. People ask all the time. So people are coming in all the time, and generally they bring something off the internet. So I would say that always is a nice little icebreaker. Here's something from the internet. It doesn't mean I'm a pothead doctor, I'm your patient, I'm not a pothead, but I read this on the internet. So now, this is some sort of validity because something I printed off the internet. That's a good icebreaker. It brings up the topic, and maybe it'll help your doctor be motivated to learn some more about the topic.
Yeah. So I hear you saying, just bring it up.
Bring it up, but don't want him to think you're a pothead, okay? Because then he's going to think you're a drug addict. People who smoke marijuana are drug addicts, and there's all these leftover images we have. Remember the doctor's worried about his medical license? This doctor's giving you controlled substances. The last thing he wants to hear that you might be using an illicit substance. So you bring it up as, here's the internet, I read this, maybe it could help me. And instead of letting him think that you're smoking marijuana behind his back.
Mm-hmm. Basically, this person is asking, if you're going to use cannabis over a long term, is there any negative side effects that come from that?
That is yes and no. Yes and no. If you smoke high THC, very low CBD, in the high milligrams of 15, 20, 30 milligrams several times a dose, there's some suggestive evidence it could impact your fetus. If you're pregnant, it may result in some low birth weight. It can arguably affect IQ, arguably, because those studies were done in New Zealand in the 70s. So there's some iffy science to suggest some problems. I would think the beneficial effects so outweigh, the well-known beneficial effects so outweigh those possible side effects, except for pregnancy. You don't want to use it during pregnancy. But not much.
You should check out, we did a fascinating class here at Green Flower with another doctor who went very deeply through all the research about cannabis and pregnancy. You'll find that the methodologies from some of those studies that were trying to validate the harmful effects of cannabis and pregnancy were in no way scientifically valid. I'm not saying that means one way or another, but you'd probably be really interested to.
It's just, and I would probably totally agree with all of his findings. But the problem is whenever we deal with pregnancy or nursing mothers, we just, I don't tell you to take Tylenol. Well, Tylenol's I'll tell you can take, but
Tylenol's okay.
You know what I mean? But there's about one antibiotic and one anti-inflammatory I can tell you can take because it's just an iffy category.
Yeah. I mean, this whole thing's a little iffy still. We're still in iffy territory, but that's why we're all here. Somebody's got to be leading this conversation forward. Is there a way for people to find pro-cannabis doctors?
Oh, yes. Yeah, and I hope it came across in the class. There's 2 websites, maybe 3 now after talking with you, but weedmaps.com, marijuanadoctors.com, which I think are both equally as helpful finding a doctor, a dispensary in your neighborhood, a doctor in your neighborhood, and also some educational material. And maybe Leafly, tell me what you can you find a doctor on Leafly?
Yeah, I believe so. Yeah,
okay.
I believe so.
A dispensary?
Yeah, definitely dispensaries.
Okay.
Definitely dispensaries and products. Great. This is a fantastic question. I'm very interested to hear your thoughts on this. So this person asked, once the cannabinoid receptors in the body have been saturated, how long does it take before the body eliminates or clears those so that you can begin functioning again?
It's a good question. So here's what happens. There's the big fat cell, like a balloon with all these little buttons on the outside, which are the receptors. And so the way they get saturated is by having these cannabinoids from the plants sitting there for hours and hours and days on end. And they actually harden, and they turn into hard, instead of being jelly-like little cups, they turn into hard cups, and they sink inside the cell. They sink down into the cell. And it takes about 6 days without any stimulation of cannabinoids on the outside of the cell for them to regenerate. They just kind of clean up their act, and the same receptors come on out. So they just sink, and then you want them to clean up with 6 day. We talked about a 6-day cleansing. So if you've been using cannabis a lot before you're trying to start this program, 6 days with no smoked, any type of cannabis, and they'll clean themselves up and they'll pop right back out.
That's great. All right, a few final questions here. So if somebody's going to approach using cannabis to transition off of or decrease opioids, how long do you think that process should take so that people have an expectation of the time frame and don't rush it?
Good question. I forgot to mention, when you talk about it with your opioid doctor, he's the main conductor of this whole thing, is your opioid doctor. The cannabis doctor is helping you with your opioid doctor. So you and your opioid doctor need to agree on a quit date. And that will depend how long you've been on the opioids, how much you're taking, what type of opioids. But you and your doctor should be able to agree on a quit date. And that date is going to be no less than a month, probably on average 3 months, and maybe as long as 6 months.
Good. I think that's a valuable expectation to set for people, though, because sometimes we're so quick to kind of think like this should just work, so I think that gives us a good time frame.
It has been, and we have the old mentality of you can just detox off opioids, and we're not doing that anymore because the people get the cravings and terrible withdrawal symptoms and hospitalized, so it's no longer the detoxing. That's old-fashioned, and so we gradually taper. Mm-hmm. And you may never come. There's plenty of patients. I'm going to say, let me give you a number, 40% may never come off opioids, but they will have dramatically reduced their opioids and their side effects. But some of these people have had 3 back surgeries. They've got a spinal cord stimulator. They've got reflex sympathetic dystrophy. They've had spinal cord trauma. They're just not going to come off opioids. Mm-hmm. But the chances of death and side effects have been dramatically reduced.
Yeah. Really appreciate you sharing all this. I think it's been invaluable today.
Good.
A few final questions for you. What do you think is the most important thing for people to get educated on in cannabis today?
Thank you. Good question. So I mentioned in the class Cannabis 101. It's a reading material that I have on the website cannabis-md.com, and it's been tried and tested. It's a nice level of reading material that teaches you about the plant, about the endocannabinoid system, about how the medicines work in our body. And then after you've got that, you have the basics, and you can take your courses on different conditions. But it brings you up to date, so you have the terminology and the understandings.
Great. Are you a cannabis user yourself, and if so, how?
Yes, I am. I use a CBD only, and it's a cream. It's kind of a lotion cream, very water soluble, for an old fracture in my ankle, and I've been using it for several months, manufactured by a company in Melbourne, Florida, and I'm just constantly impressed by how quickly it takes the pain away. So that arthritis is not going to go away where the fracture didn't quite heal, so it's not going away. So if the pain is not going away, the arthritis at the fracture is not going away, the pain goes away, and then I'm functional. And so it works great for me. I love it.
Awesome. And finally, what's the most important lesson you want people to walk away from this class today on cannabis and opiates?
Well, I hope they open their minds to this topic, and they're going to go out and read more about it and introduce others, family and friends and people at work, to the idea of how to use cannabis, especially for this particular topic of opioids.
I think this is absolutely life-saving information, and I really appreciate you coming on to share it with us.
Well, great, thank you. I really enjoyed it, Max.
Yeah. All right, everybody, a few final thoughts before we sign off today. For you that are medical practitioners or you want to give something good to your doctor, I would pick up Dr. Greg's book, Medical Cannabis, What Clinicians Need to Know and Why. It's very well written, and it's a great way to introduce clinical people to medical cannabis. I also want you to know that if you missed any of this class, If you'd like to re-watch parts of this class, if you have other people in your life who should watch this class, we want to really encourage you to become an insider, which is our exclusive membership program that gives you unlimited access to every single cannabis class that we've done here at Green Flower. And that's thousands of dollars worth of training in all different forms of health and medicine, as well as the different parts of the industry and growing and cooking with the plant, and basically the entire range of cannabis topics we have classes on. But also, every week as we're producing these classes, we'll automatically add them to your library. And this is all for less than the price of one pizza each month. So it's an amazing opportunity for you to really learn everything you can about this plant and really stay on the front lines of what's happening and what's unfolding in the cannabis movement. If you want to keep engaging with us, keep showing up to learngreenflower.com on a weekly basis, see all the new classes and events and things that we're doing here. And as always, we're so grateful to have you tune in to learn everything you can about our favorite plant. Have a good night, everybody. We'll see you soon. Hi everyone, Max Simon here with a special announcement. Our friends at Ebna, which is an Israeli terpene company, sent us 150 of these basic terpene dictionaries. And boy, is it cool. You'll see inside here it has terpene flavors of 3 different blends, a limonene, pinene, and linalool, as well as 3 different strains, Super Lemon Haze, OG Kush, and Granddaddy Purple. And these little discs actually have the terpene content inside of them so that you can smell them and really understand what they are. And this is so cool because not only will it help you really pick out these fragrances in your cannabis, but it's just a very cool experience to really understand the true nature of these terpenes. And the coolest part is that we're giving 150 away for free to insiders. Now, you'll have to pay shipping and handling, but that's nothing in contrast to how much this terpene dictionary would cost you. So go ahead and become an insider today. If you're already one, great, your name will already be entered. And we'll look forward to seeing what your experience is like when you get to smell these terpenes for yourself.